Hello, I'm Marwan Aburas. Traditionally, in practice, hopeless infected endodontically treated teeth are extracted and the site of the lesion is curated. Sometimes this course of action unfortunately results in even larger bone defects, necessitating subsequent bone grafting or augmentation, either horizontally or vertically. So clinicians are then positioned to either place an implant immediately or hold off till we have healing and they do the implant placement later on. So the question, what is a hopeless endodontically treated tooth? Teeth could be hopeless because of restorative reasons. They could be because of endodontic reasons such as treatment failure, perforations, broken instruments, root fractures, etc. This is the topic I would like to talk about today. I have a technique, an alternative technique of a great value. I do not extract endodontically treated teeth with lesions. I use them for a functional, biologic, or a clinical purpose. I use them for interim period of 9 to 12 months. That affords sufficient time, ample time, to predictably and safely eliminate the alveolar socket infection. That's key. The tooth may be hopeless, but the socket is not. The socket has potentials to regenerate and give you new bone, native bone, patient's bone for future implant placement. So this technique was introduced first time in the Journal of Oral Implantology in 2010, I think, yes. And then later on, I had the honor of presenting the technique to the American Academy of Osseointegration in 2020. And I'm planning to put that video, which is about 20 minutes later on after this video. Okay, so you'll have more in-depth knowledge of the technique. Anyway, what is the technique? The technique involves performing surgical endodontics. And surgeons, periodontists, plat surgeons, trained GPs can do that easily. And that basically, you have the endodontically treated tooth failure, that all you have to do is lay a flap, do an apical curettage, discover the cause of failure, do deep apicoectomy or retrofill or root amputation, whatever is needed. The objective is to entirely remove the cause of the failure, okay? That could be just deep apicoectomy because many times the fractures are only at the apical third, okay? So what's important, notably, I do not place any bone augmentation. I do not put any bone augmentation into that defect, okay? Because I wanted to leave it for original bone regrowth. In order to easily observe the healing process through taking a PA, because if you place a bone augmentation, it's opaque, then you will not know which is artificial, which is original bone patient. So this way, we know exactly the new opacity is the new bone. Just in a span of 9 to 12 months, this is all you need, okay, to have a new regeneration. At this stage, okay, 9 to 12 months, the hopeless tooth is extracted and now becomes very easy extraction because you lost half of the root or root amputation, whatever. So becomes a simple extraction and a simple immediate implant placement. So what are the advantages of this technique? The new bone, the new grown bone is the patient own bone. This is important. It's native bone. It's not artificial, okay? And it is superior. It's a superior base for osseointegration than the artificial bone. The process, okay, reduces the need for bone augmentation, which takes time and many times you need to wait. Notably, the method really important to me that it keeps you away from exposing the sinus, injuring vascular mental foramen, alveolar neural bundle, etc., etc. So it is conservative technique. It's a good technique. It's biologically sensible and clinically dependable. I've done it now for so many years. And the approach maintain function. That's what key. You still have that hopeless tooth aesthetically there, functionally, the patient eating and having 100% predictability that underneath it, you have a new bone regeneration. Okay? So later on, you could see the video, and I thank you for listening.